Okay, welcome everybody to the Charles C. Jones Seminar. And today we're pleased to welcome our Nazarian. Professor Nazarian has a faculty appointment at Harvard, but also is at the Beth Israel Deaconess Medical Center, where he holds a chaired appointment as the vice chair for research as well. And as we think about innovation and impact at Dartmouth and how we're going to grow into the presidential priority, I think this is a great opportunity for us to see how it's being done at other institutions. Very specifically, Dr. Nazarian merges biomedical engineering, medical imaging, and translational science in his research, and that means it's been funded by NIH, DoD, through SBIR's startups, so everything from foundational science all the way through translation. And I think this is a really great opportunity for us to learn from an esteemed colleague just down the road from us. So with that, thank you to Dr. Nazarian, and we look forward to your talk.
Thank you. Thank you very much. Thank you for the invitation and to be here at Dartmouth again. I absolutely love this institution, and this is a wonderful department with the dean's leadership and great faculty and you guys. And we've had the pleasure of working with a few of students from this program in our lab, and it's been a remarkable experience. So today I'm going to talk to you a little bit about rotator cuff tears. It's an area that we've done research over the years, and in some of the issues that arise from rotator cuff tears and the means to be able to sort of potentially prevent some of this damage that occurs in patients and not let it sort of get out of control and to a point that, there's no mechanism that you can at the moment repair these tears. So briefly, a lot of funding on disclosures that we have. In terms of issues, so the rotator cuff tears are one of the most common sort of tendinous injuries that you see in the general population, mostly attributed to aging and degeneration, and the result is, with increasing prevalence with age. So the consequences of rotator cuff tears are severe because they result in pain, loss of function, and also makes work and daily activities painful and difficult. And because sort of these injuries are so common and debilitating, sort of the healthcare expenditure result in sort of upwards of $40,000 per patient that is spent on these. And there's a few, 5.7 million visits a year for shoulder problems. So that's a large number. So this is certainly an area that we could try to make some inroads, and the large majority of these are basically pertaining to rotator cuff tears. So the human shoulder, as the main sort of actor in this place, is a remarkable joint. It has incredible range of motion and power, and enables elite athletes to do amazing things such as throwing a baseball at high speed. But also with this same mobility and structure comes at a cost. And over time, you have repetitive stress and aging that lead to instability, tendon damage, pain, and sort of making the shoulder one of the most injury-prone joints in our body. And get to philosophize a little bit about shoulder. And so Charles Darwin noted that, apes are unable to throw with precision. So a uniquely human ability that is something that we were reminded by him. So the simple observation highlights how sort of throwing may have been a sort of key evolutionary step that links brain development, tool use, and the emergence of complex motor coordination in early humans. And this is a wonderful paper that came out many years ago. And this paper, we talk about our ability to throw with speed and power basically comes largely from how our human body stores and releases elastic energy. And so we have tall mobile waist that allows us basically our hips and our thorax to move independently. And this sort of decouples the increasing torso rotation, which in turn sort of boosts the torque production that we have across a large range of motion. If you look at this, this is not present, as you can see, and chimpanzees are close relatives. So the humeral head orientation, and also the elbow and the angle that, the axis angle that sort of plays a role in this too. And in humans, these angles are about 10 or 20 degrees lower than in chimpanzees. So this sort of reduced torsion extends the external range of motion that you would get, that enables us to have greater elastic energy, sort of storage in our shoulder, and also have a sort of helps with the wind-up phase. And finally, with humans, we have a more laterally oriented glenohumeral joint. So this alignment allows the pectoralis, sort of major's flexion, sort of to act along the same axis as the torso, and results in what we can rotate the trunk. Motion efficiently transfers power from there into your throwing arm and maximizes both speed and force. And if you look at the pitching motion of a pitcher, you truly see that in a slow motion pitch and how this entire operation sort of comes together and results in delivering a ball that, releases the pitcher's hand at 100 miles an hour. So it's remarkable. And so spear throwing may have been the key motor skill that sort of stimulated the evolution of the human brain and the coordination that you need, the precision and the planning that you need in terms of you're using your cerebral cortex and sort of all these advanced, sort of motor controls that that you have in a large brain size, language, opposable thumbs. And so this complex tool set that we have, and throwing being one of the most earliest and one of the most sort of transformative components in human evolution that basically allowed our ancestors to affect change at a distance, protect themselves from predators, hunt for food, and compete with other hominins for resources. So I like to think of it as a defining behavior that connects movement, intelligence, and survival in human evolution. So if you look at the sort of a throwing motion, accurate throwing depends on perfect timing. You release it too early and it goes too far. You release too late and it falls short. So the window for success is incredibly narrow, and basically doubling the distance makes it 8 times harder to throw accurately. So to hit the target, your brain has to sort of put all of this together, your muscle activation in advance, and all of this will be able to affect change at a distance. So with all of this philosophizing, what do we do that is important? So throwing with precision is uniquely human. And we use throwing as sort of, one of the key sort of activities that you do with your shoulder. And I'll get to that in a second. And understanding it sort of inspires us to build a better mousetrap. And our idea has been to sort of do what you like to do and solve complex problems and sort of try to figure out how best we can come up with a approach that will help us understand rotator cuff tears and the burden of the stress that you have on shoulders and how you can predict these tears from early on, so you can potentially do something about them before they turn into a tear. So all of this philosophizing only happened because I tore my gastroc muscle when I was early faculty postdoc, and I went to see Dr. Ramappa, who is one of our sports medicine docs. That we sort of grew up together in the system. He was a med student, worked at our lab and everything. And he was like, "Why don't we do research together?" And I was saying, "Sure." And that's how our entire shoulder research started. And we had a throwing bent to our work from early on because we got a grant from Major League Baseball to look at rotator cuff tears. And so that sort of that evolution of that, but then evolved into, looking into a very narrow scope of rotator cuff tears in athletes, and to now going into the greater population and seeing sort of the effect of shoulder motion and how it, and the level of damage that occurs in patients and humans over time as they age and with repetitive motion and things of that nature. So that's 95%, 98% of the problem. Acute tears from throwing a baseball is a tiny sliver of that. So, but you can use funding from that to understand the other one better. So basically talking about the shoulder anatomy. Shoulder anatomy is basically likened to a golf on a tee ball. It's constructed to have a maximum range of motion. So there's no joint that you have this much range of motion as does your shoulder, but it comes at a cost. The bony structures that, affect this motion are minimal, and most of your motion is occurring through soft tissue. So there's muscles and tendons and everything that sort of keep this joint in place and allow this range of motion to happen, which is great, but also comes at a cost. So the rotator cuff is basically comprised of 4 muscle tendon units. We basically play in a pivotal role sort of in stabilizing your glenohumeral joint, which allows for this large range of motion that we talked about. And of particular interest is the supraspinatus tendon, which is, and by the way, these are terrible muscles. If you do any kind of an EMG, they're terrible muscles to study because they sit on top of each other and they're all flat. And you can't put a needle in them and you can't really measure them well because they all interfere with each other. So it's a mess. So supraspinatus tendon, which is basically subjected to high tensile loads and helps initiate the movement in the human, during abduction. And it's sort of the only tendon that does not play a role in rotation, making it particularly vulnerable to injury and degeneration. So the ability to resist and bear such loads comes from the structural composition of the tendon, which is shown here, which is largely comprised of collagen fibers, basically, that have a hierarchical structure with the amino acid backbone of repeating units of, glycine, proline, and hydroxyproline, which you all know, all the way to the collagen fibers, which is basically highly aligned along the tendon, giving it sort of its high tensile strength. So what's also interesting about supraspinatus tendon is that it's the most commonly torn rotator cuff tendon, and the anterior supraspinatus tendon, as you can see here, has long been described as a location of tear initiation. With what makes really interesting is that it's been this area called in the STAR called the critical zone, which is basically avascular. So damage occurs, and there's no vasculature in that area. So and this is one of the main reasons that you have poor healing environment in that area, and the lack of vascularity, and this poor healing environment, a lifetime of use and abuse, and often sort of results in pathologic degeneration in that area, which basically eventually moves into a tear. So the limited healing capacity also contributes to this propensity for rotator cuff tears to progress over time rather than heal. So there's a mismatch between repair and damage, and that's where sort of the problem lies. And so ultimately what happens is you have a lack of vascularity, you have poor healing and lifetime use that ends up with, damage and tear over time. So this results in a joint that has a large range of motion, relying on coordinated dynamic resolution, where a small insult results in a significant injury. Ooh. This thing came off. So let's see. All right. Okay. What here we want to talk about is aging, and this highlights the growing clinical impact of rotator cuff tears. Basically, here you see that Scher and Yamamoto showed in these two studies that there's a dramatic rise in tear prevalence from roughly 20% in smaller cohorts to nearly 70% in larger, older populations. And this trend demonstrates the urgency of improving predictive models and also preventative strategies that, as rotator cuff pathology remains one of the most common and debilitating musculoskeletal conditions, and being able to figure out this predictive, coming up with predictive means to be able to understand how this happens could significantly impact the burden of disease on patient populations. So what we've learned is that pain is not equal to tear. Tear is not equal to pain, and partial tears eventually turn into full tear in some cases, but in some cases they don't. So it's a mixed bag. So the question that we want to answer as part of this work, and most of the work what I'm presenting today is work done by Mason Garcia, who was a PhD student at our lab, and he graduated recently and is in med school at the moment. And unfortunately, we didn't punish him enough so that he actually got into medical school. And Gabe Landy, actually, who one of our students here, was an intern in our lab, and he has been a remarkable contributor to this work as well over the years as an intern, and then he kind of helped us with our projects. So the key question that we want to answer is, where do tears initiate, and how do mechanical properties change over time? And our hypothesis is that tears will initiate posteriorly and progress anteriorly, and as tear sizes increases, there will be a decrease in mechanical function. It doesn't take a rocket scientist to come up with that. So that's what you think. But it's also important to be able to show that and to demonstrate. So look at some of these figures. And most commonly, rotator cuff begins, so most of them begin as small asymptomatic lesions, where longitudinal studies have shown that progressive and sort of progression and enlargement of asymptomatic tears linked to development of symptoms. So therefore, making it's sort of important to understand which tears are most likely to progress or not. So that's one of the key functions. And you could see here, this is, and one of the more challenging things with musculoskeletal and most specifically orthopedic health is we don't have a lot of standards on how we look at things. So everybody decides what they consider as a tear size. It's a small, medium, or large, and what is progression and all that. So that makes it much more difficult, and that's why we went through all this effort to try to figure out what the literature says about some of these things and understand what constitutes as tear progression, or what is a small tear or a medium tear or a large tear. And similarly, so we cover. So here, for instance, we have, they present in rotator cuff tears present in different shapes and sizes. There are many accepted classifications, which says sort of the anterior, posterior, so like the side to side, or the medial lateral dimension, and also the number of torn tendons that are involved. So what happens is these sort of oversimplify a complex geometry and a complex pathology into a single number. And what happens is, this number is not really commensurate to exactly what happens to these tears over time. So we went through the literature. So many studies have sort of evaluated the natural history of the rotator cuff tears and try to identify the risk factors that are associated with tear progression. Despite the growing body of literature on these rotator cuff tears, that we've seen that there's no unanimous risk factors to identify which tears actually may or may not progress. So the two factors that basically I want to bring to your attention here, where we can see that there are conflicting results. However, in these two factors, you see that both tear width and tear retraction, these are the two that had the most sort of agreement among all the papers that had been submitted as to had been looked into this problem to attribute to differences in classification systems, or their inability to sort of for this tear to be based on other biomechanical behavior than what you would see based on just a simple size. So taking this, we know due to various classifications and definitions for tear progression, there's still a lack of information in predicting which tears may or may not progress. So that's sort of where our problems are. We saw that progression of asymptomatic tears may lead to the development of symptoms, but the progression of symptomatic tears is also of importance, as tear enlargement may lead to worse clinical outcomes. So particularly when you have conservative management and physical therapy is unsuccessful, and knowing that which tears will progress, it actually would be beneficial clinically. So you can make sure you can tear treatments, treat these different tears accordingly, so you don't actually make the problem worse by going to a route that would not result in better outcomes for the patient. And another downstream sort of result of rotator cuff tears is the degenerative effects of the glenohumeral joint. So as rotator cuff tears sort of alter the biomechanical environment and result in less stabilization of the humeral head, this has an effect on the actual joint itself. So it has been reported that up to 26% of the patients with glenohumeral OA also have concurrent rotator cuff tears. So this affects your rotator cuff tear, affects your joint motion, which in turn affects your overall joint surface health. And the presence of articular cartilage degeneration is more common in shoulders with rotator cuff tears than without. So what we can see is that when the tear becomes large, we get superior migration of the humeral head, which results in abnormal wear and ultimately rotator cuff arthropathy. All right. So what we do? So what is missing here? Where do tears initiate, and how do the mechanical properties of these tendons change over time? How does the tendon structure change due to rotator cuff tear, and can this be evaluated non-invasively? What are the compositional and mechanical alterations to the glenohumeral joint due to arthropathy that you see in the joint? And can the relationship between these rotator cuff tear size and mechanical function better identify which tears are more likely to progress? So to do that, we went through a series of studies that sort of looking at the impact and prevalence of rotator cuff tear. We talked about that. Initiation and progression of rotator cuff tears through ex vivo fatigue loading, looking into the relationship between tear size, quantitative magnetic resonance imaging, and rotator cuff tendon mechanics. Then looking into mechanical and compositional changes to the glenohumeral joint resultant from degeneration, and then clinical translation of this to be able to predict rotator cuff tear progression. So first thing we did was, all right, so we subjected, it was one of our first studies that we did with Mason, that we subjected healthy defect-free cadaveric supraspinatus tendons to a fatigue loading regimen. Basically, we take serial images every 500 cycles to capture the initiation and changes in tear size over time and to assess their mechanical properties. And the goal was to identify location of tear initiation, changes in tendon mechanics tear as they progress, and then classification based on mechanical changes. So we've been doing a lot of work in this area, and it's interesting that nobody had really looked at this study. Nobody had done like a basic study of you cycle through a rotator cuff tendon enough to you start from an intact one and all the way to see where tears occur and how this process changes. So these were long studies. There's tens of thousands of cycles in some of these. So it occurred over time, which with all the limitations of having an ex vivo tissue that you subject to testing over many, many days, that you make sure you keep the specimen moist, and then you put them in a fridge overnight, and then you bring them out the next morning and you do this. And being able to sort of do that, and at every 500 cycles, you'll be able to take a picture to see exactly what's happening over there, to understand how this visually, where does the tear initiate and how this thing progresses. So this was a long study. It took a lot of patience, took a lot of effort, but we thought it was important to sort of understand how things start to go south and where do they start to go south. So through fatigue loading, we found that tears begin to initiate basically in the middle posterior third on the supraspinatus tendon. And throughout their fatigue life, basically, tears progress anteriorly, increasing both in size and until failure. So I think, is this a video? So this video, there you go. So this rendering was done based on actual data that we had from images, and created a video that would basically shows how these tears progress over time based on this data that we collected. And so what we saw was that to assess the changes in the mechanical properties over time, we evaluated two damage coefficients. But basically that taking into account the current behavior relative to the initial behavior, and calculated using these equations that you see here over the stiffness and strain, looking at the damage accumulation basically, and the linear region of the FT curve, and the displacement actually, which was then converted to strain, and then calculated at every 500 cycles to assess the relationship between tear size increases. And we see that there's an increase in both the stiffness and strain sort of damage parameters that signifies a higher degree of damage, decreasing mechanical function in both of these. And we found that the total tear area, which takes into account sort of the AP and the ML dimension, is a better predictor of the mechanical degradation experienced by the tendon compared to either AP or ML size. So the tear area turns out to be a better predictor than either one of these dimensions alone. And here, so while we showed that tear size predicts sort of the mechanical degradation, to better understand how this actually could be translated to clinical practice, we wanted to identify when these changes occurred. So we found that there was also two distinct points in the loading cycle when mechanical changes occur. The first was when tears progress to be larger than 100 square millimeters. And the second one was when the tears sort of increased to be more than 400 square meters. However, 75% of the samples that actually failed prior to progression past 400 square meters, and the data shown in this column in these two columns, the data that you see that ultimately fade around 500 or 600 square millimeters respectively, which indicated that sort of, if you look at this, like anything greater than 300 square millimeters may be relevant, as this is when the majority of the tendons sort of exhibit this complete rupture behavior. And so now the two things that are interesting is that that area is a better predictor than either dimension, and that there is a mechanical component to this as to when you see distinct changes in the phases of the mechanical behavior. And so, where do tears initiate and how do mechanical properties change over time? We see that rotator cuff tears initiate more posteriorly than previously thought, and then approximately 16 millimeters posterior from the anterior edge of the supraspinatus tendon, which lies within sort of the critical zone. And then tear area, rather than AP or ML tear dimensions, is a better predictor of the biomechanical changes as rotator cuff tears progress. And then these thresholds where there are biomechanical changes that occur as part of this process. So next, how does the tendon structure change due to rotator cuff tear, and can this be evaluated non-invasively? So to look at this, to evaluate collagen in the healthy and torn tendons, we performed Raman spectroscopy at Mike Albro's lab at BU, basically looking at non-destructive optical light scattering, and to sort of provide us information with the chemical structure of the tendon, and second harmonic imaging on these tendons to assess collagen fiber orientation. And after that, we did QMRI, quantitative MR imaging on these tendons, where they were subjected to T2 mapping protocols, and we looked at the T2 relaxation time, basically, that reflects the mobility of the water molecules in your tendons, which actually can be altered by sort of your collagen organization and your density. So it's a surrogate for what's happening to the collagen network. And at the end, we performed uniaxial mechanical testing on these to assess their load-bearing capacity. So what we saw was I wanted to highlight the fact that the current classification systems fail to illuminate the mechanical differences between tears, which could explain why some of these tears actually we do not know why some of these tears actually may or may not progress, and that they're sort of grouped in a fashion which fails to account for their mechanical differences. However, there's a relationship between tear size and the mechanical function, as we see that for both tendon stiffness and failure load, increases in tear size is strongly correlated with a decrease in strength, indicating a need for the reappraisal of when the mechanical properties change, and to further validate that idea that tears actually are grouped based on tear area. And we see a similar trend in which tears that are greater than 100 millimeter squared, actually there's a decrease in their mechanical behavior, although there's no difference between intact and small tears in these groups, which also may explain why some asymptomatic tears often have high levels of function. So here, we looked at the Raman data, and we see that the collagens, the amino acid chain is, you have the, glypro hype, you have the, glycine, hydroxyproline, and then you have proline components in your rotator, in your collagen. And basically, what happens is, with this Raman spectroscopy allowed us to evaluate the biomechanical changes, biomolecular changes that occur due to rotator cuff tears. So where we look at the two specific peaks in this data, we looked at the proline and at the amide peaks, I think. In these, we looked at the hydroxyproline, sort of the two peaks on this, and we saw that the Raman bands were actually fit to determine the area under the curve, and then normalize this to the amide 3 peak, which is basically relatively stable and exhibits sort of the changes to degeneration has been used in normalizing this behavior for tendon. So looking at these peaks, we can see a decrease in the intensity between the two, between the control and the torn data. You can see there's a decrease in in the intensity in the torn group, basically quantitatively, we see there's a reduction in the proline and hydroxyproline spectral biomarkers. And which basically indicates an alterations to the collagen structure. And then these changes show a significant relationship with the tendon's mechanical function, as you see on the far right. And the more prominent the pro and high biomarkers are, the greater the failure forces. So then, in a subset of healthy and torn tendons, we did second harmonic imaging on these, and I looked at the changes in the collagen orientation, where we could visually see the loss of alignment at the bottom row on the torn samples, and the disorganization of the tendon structure. From these images, basically, we generated maps to quantify the circular variance and the damage area fraction. And the circular variance measured the sort of the degree of disorganization, and the damage area fraction sort of quantified the regions that have greater than 10 degrees of difference from their neighbors. And we can see that on these images, the green identifies the intact regions, and the red highlights the damaged regions as part of this process. And comparing these, we see that rotator cuff tears result in more disorganization and damage in them compared to the intact specimens. And to measure these sort of structural alterations, so remember, none of these, second harmonic imaging or Raman spectroscopy can be done in vivo at the moment. There's people that are working on probes for Raman spectroscopy that could be used in vivo, but I think that's a process that it will take some time for them to work. But none of these can actually be done in patients. So we looked at MRI. So we looked at to measure these structural alterations non-invasively, and basically we did quantitative MR imaging to look at the T2 relaxation time, where we see that in the torn tendons, the average T2 relaxation time from basically between significantly higher than the normal one. So the T2 relaxation time was also strongly correlated with tear severity in these sample. And so as tears become large, so that basically what you see is as tears become larger, the T2 relaxation time also increases. And when assessing these torn tendons, we found that T2 relaxation time is indicative of tendon function. So a reduction in both the stiffness and failure force as T2 relaxation time increases, which shows that T2 relaxation time potentially could be useful as a non-invasive biomarker in evaluating tendon health. So how does the tendon structure change due to rotator cuff tear, and can this be evaluated non-invasively? So intact and small tears have similar mechanical properties. So this is part of the reason that some of them are asymptomatic, but they're fully functional. And so that's an important thing to know. And also tendon degeneration results in alterations in the collagen matrix in the form of the disorganization of the network and a reduction of the proline and hydroxyproline spectral biomarkers. Basically, this potentially can explain why we see an elevation in T2 signal in MR imaging. So next thing we did was what are the sort of the compositional and mechanical alterations to the glenohumeral joint that are resultant from rotator cuff arthropathy. And for this work, what we did was to evaluate sort of the cartilage composition. We used Raman spectroscopy, and also we used they have a novel spectral decomposition technique, basically, which can identify ECM constituents, which is glycosamine glycans and the collagen and the water, the key components of the articular cartilage, along with biochemical assays to sort of verify our results. A subset of the healthy and degenerated sort of specimens that we had, we also subjected them to micro-CT imaging to evaluate the trabecular bone structure underneath the articular cartilage, and which also is affected by due to OA changes. And lastly, we subjected these specimens to indentation testing to obtain sort of the compressive modulus of them to characterize the functional deficits, basically, that you see due to degeneration of the articular cartilage. And ultimately, the outcomes were to assess cartilage degeneration and early OA changes in the glenohumeral joints due to rotator cuff tear. So we can see sort of the two Raman spectra and these images you can see from intact and defect specimen. And you can, the multivariate regression analysis, we saw that, there's a relative amounts of GAG, collagen, and water. And where we can see there's a reduction in the GAG, you can see in the red that there's a reduction in the GAG. And sort of we generated a spatial sort of map for the mechanical and compositional properties of the humeral head. And with increasing levels of degeneration, sort of we were able to basically we're able to show the compositional and mechanical changes that occur due to degeneration. And from this, we can see that in the defect regions, in those parts, there are changes in composition and softening of the cartilage. Yet for small defects surrounding regions, actually, you may exhibit normal behavior. So here, looking at the specimens with both rotator cuff tear and OA versus those that just had focal defects and no rotator cuff tear, we see that the location of degeneration appears to shift inferiorly, which is a characteristic of rotator cuff arthropathy due to this sort of the superior migration of the humeral head, which results from abnormal wear. But what we wanted to do was we really wanted to explore if the compositional and mechanical alterations differ between these specimens. So as a result, we compared the Raman biomarkers between the rotator cuff tear plus OA group with OA only groups and found that there was no difference actually in the compositional and mechanical alteration between the groups. So which tells us that these changes sort of manifest similarly, although they may differ in location. As a result, all defects regions were pulled, and because of that, we sort of pulled all of the regions together to analyze the data together, because as we saw, there was no difference in the compositional and mechanical sort of behavior of these. And what we saw was that looking at the humeral head, sort of that contained defects, we wanted to compare the regional sort of with visual degeneration versus those that had no visual signs of degeneration. And the visual signs of degeneration were actually done by one of our orthopedic surgeons, using clinical criteria that we use for this, that they use in clinic for this. So that's how the visual sort of, degeneration was quantified. And we wanted to compare the regions where, visual degeneration versus those that had no visual signs of degeneration, and to highlight basically the changes in composition and mechanics. And when comparing these groups, we saw that there was a significant reduction in GAG and collagen with an increase in hydration, which ultimately results in weaker and less stiff cartilage. So we saw a reduction of GAG, collagen, and increase in water. Obviously makes for a softer tissue. So, we also wanted to compare sort of the Raman biomarkers to biochemical assays to make sure we validate our findings. And when, grouping all sort of intact versus the defect regions, we saw that the same trends in the biochemical assays as we found them with the Raman, spectroscopy. And, we saw that there's a significant loss of GAG and collagen and increased hydration. So, as part of this, while we've shown that there are compositional and mechanical sort of alterations to the cartilage, we also want to highlight that these alterations change the mechanical properties and compare this to clinical scoring of cartilage health. So we use our clinician colleague used the outer bridge scoring system, which is basically a visual grading system to determine the degree of damage. And we showed that there's no correlation between outer bridge grading and the mechanical health of this. However, when assessing the composition, we see that the degree of GAG in collagen is strongly correlated with the cartilage's ability to resist compression. So, and finally here, we talked about the micro-CT data. We wanted to assess the changes to the bone architecture. So where we've shown here is micro-CT images of a specimen from a healthy humeral head versus one from a specimen that has a focal defect. We compared the rotator cuff plus OA group versus the OA alone group to see if there was differences in the degeneration of the bone. And as the underlying bone, mostly trabecular bone, on an OA surface, you see a lot of sort of, signal back and forth between these two. So the vicious cycle that basically you degenerate the tendon enough, the cartilage surface enough that actually it penetrates and it affects the bone, and the cytokines are released, which further degenerates the articular cartilage. So we see that changes manifest in a similar fashion. When comparing sort of the defect regions to the healthy controls, we see that there's a decrease in trabecular volume, BVTV, bone volume over total volume. And then there's an absence of sclerosis or increased bone mineral density. So there's no changes in the bone mineral density. So the content of the bone changes, but not the bone material in and of itself, which is consistent with basically what you see in degenerative changes in early to mild OA. So what are the compositional and mechanical alterations to the glenohumeral joint due to rotator cuff arthropathy? So we see that degeneration to the humeral head results in distinct changes to both the cartilage and the bone, and highlights the downstream effect of rotator cuff tears within the glenohumeral joint that actually points to a better understanding of which tears may progress and how further progression will result in joint level degenerative changes. So now the question is, can the relationship between rotator cuff tear size and mechanical function better identify which tears are more likely to progress? So for this, we looked at a study of 82 patients from BI who had repeat imaging with isolated partial or full thickness or supraspinatus tears. So basically, we did a retrospective review of these patients and looked at AP and medial lateral measurements were taken from the MR images to assess tear morphology. And in and of itself, this is a source of bias. So if a patient has already had multiple MRIs, so it's already a biased database. So just wanted to be clear about that. But this allowed us to actually be able to follow to see if there's any changes that you can sort of follow over time in this population. And the goal was to look at the tear progression in isolated both partial and full thickness supraspinatus tears, identify sort of tear area as a risk factor for progression, and assess whether our biomechanical tear size classification is useful in this clinical setting. Okay, so I wanted to revisit sort of the current definition of rotator cuff tear progression and the classification system, and highlight that both partial thickness and full thickness tears, the current classifications fail to illuminate the full nature of the tear and depend on only one dimension. Basically, this leads to inability to predict which tears actually progress or not. In two of our studies, we found that tear area more accurately characterizes the biomechanical changes that you see as tears progress, and that these thresholds can be used in a clinical setting, hopefully. And so we're proposing to use the following sort of classification systems, which is based on tear area, both AP and medial lateral dimensions, to better understand which tears will progress. And this is another point of looking into altering clinical care. So what you want to do is you want to be able to work in the confines of clinical care, how physicians, radiologists, or whatnot are used to seeing things and evaluating things. So you end up having, what I've learned over years, you end up having a much better buy-in from clinicians if you propose things in a way that it's familiar to them and it makes sense as a sort of the next level evolution, as opposed to a brand new concept that they have not seen before and have not been exposed to. So since they already do these measurements, and we see that these measurements do have value when you combine them to look at the area of the tear as opposed to each one of these dimensions, based on our interactions with them, it appeared to be a easier way to sort of get them to agree to sort of change the way they look at things. So that's sort of one of the motivations also that we looked into this. It was easily adaptable. So here you can see two tears. You have an AP tear width of 8 millimeters and a medial lateral tear length of 8 millimeters. So the total area is 64. On the other one, it's 66, but it's an 11/6 tear. So these two tears would be classified differently. However, from a biomechanical perspective, they behave similarly because one is wider than the other one, but biomechanically they actually act very similarly. So in this case, for partial thickness rotator cuff tears, when evaluating which tears progress to full thickness tears, and full thickness is when you go to the entire thickness and the tear basically is full severed. So we found that tear area at initial MRI was a significant risk factor for the conversion to full thickness tear. So as the tear area in the progress group was larger than the tear area that was in the non-progress group. So also, there were no differences in the demographics, comorbidities, and the differences in follow-up time were not significant in these populations. So based on our tear area classification system, we found that small tears progress 54% of the time. However, medium tears or tears that are greater than 100 millimeters square in size progressed 82% of the time. A big difference between these two groups. So each 50 square millimeter increase in tear area resulted in a 15% increase in the risk of conversion to a full thickness tear. So for full thickness tears, it becomes much harder to predict which tears will progress or not. As there are many classification systems and definitions of tear progression. However, the most commonly assessed one is that any tear that's greater than 5 millimeter change in AP or ML is considered to be progressing. So when assessing which tears exhibited this change or not, we see basically that at the initial MRI, both the progression and non-progression groups appear to have similar tear characteristics. And ultimately, this suggests that the current definition and the current classification fails to explain which tears progress. Now, while the current definitions fail to account for the full tear morphology or the biomechanical changes that you would observe, the present classification system accounts for these biomechanical changes. And therefore, tear area can be used as a risk factor to assess which tears may or may not progress, and when looking at the small tears. And we can see that at the initial MRI, basically the progression group had significantly larger area compared to the group that did not progress in their size. Similarly, when we assessed the medium tears that progressed into large tears, we saw that the initial MR tear area was significantly greater in the progression group versus the non-progression group. So ultimately, can the relationship between rotator cuff tear size and mechanical function better identify which tears are more likely to progress? What we do is we would like to propose a biomechanically based classification system which accounts for full tear morphology, showing the tear area may be a better indicator, basically to identify the risk of conversion, and increase in tear classification. Okay, and here, so you can see like where do tears initiate and how the mechanical properties change over time. You have the initiation, you have tear area, and then you have further progression, reduction in mechanics, and changes in the collagen fiber orientation, which is subsequently visualized, quantified by changes in the T2 mapping properties in these patients. And then you could see that, increased GAG and collagen, in healthy sample, you have high GAG and collagen, you have low water, and in degenerated tissue, you have the opposite of that. And sort of looking at whether this, this relationship between the rotator cuff tear size and the mechanical function can better identify which one of these tears are more likely to progress. So ultimately, we look at this. You have surgical intervention, you have physical therapy. These are the two ways that you treat these patients. So you have the tear progression, you have symptom relief if you use physical therapy. And if not, you have intact repair. Has the repair failed with symptomatic relief? So how does this work? How does this then turn into development of OA and then subsequent muscle degeneration? Because now you have you basically end up with a case of an unloading of your muscles because of the damage that you have in your tendon. And then sort of the goal is how can we further assess rotator cuff tears? So what we need to do is this is like 4 years worth of work that has helped us better understand what are some important things to consider in your tendon, and how that potentially could allow us to find a way to better assess, to better predict which tendons fare and which don't. However, this is, again, 82 patients from a sample size that is, it's a retrospective study. And what we really need to do is we need to do a longitudinal clinical assessment on these patients. You need to have an actual group of patients. We need to follow them. We need to classify their tears by biomechanical function, and then look at the preoperative tendon integrity and the post-intervention assessments via T2 mapping. So better understand that. And another aspect that I didn't touch here, but I mean, there's radiographic changes in the cartilage and muscle health. So radiomics actually can play a significant role here, which we have done some work on this, and I didn't have it in this presentation. But looking at a combination of T2 mapping, changes in T2 mapping, changes in radiomics of the bone, which is the features that you can use machine learning tools to look at changes that are not visible to the human eye in these MR images, sort of allows us to have better understanding of what changes, what tendons tend to predict them to fail and which group does not. And the other aspect that again didn't touch upon here is that and part of this is we have submitted an R01 on this, that we have been collaborating with a group from Italy for 3-4 years. We have enrolled 100 patients there. We have all of this data. We actually have serum data and tissue sample data from all of these that you can actually look into biologic markers. You can really assess whether at the sequence level, at the protein level, are there differences between those that have torn but those that have not torn. Unfortunately, we could not use our collaborators in our R01 grant because we cannot have foreign entities into our grant. So significantly changed our work. And this is 3 years of collaboration and 100 patients that have been enrolled. So a lot of this, this is work that has been done by Mason et al. Lab that built on what previous PhD student et al. Like Patrick Williamson did. And it's only covering a part of that. And the idea is that now what we've learned, now we have to see if this is true. And so take this and then go into a real set of patients, look at them, understand how their T2 mapping works, understand how the radiomics work, look at their, look at the proteomics and transcriptomics of these patients. Is there anything that we need to learn from these populations that are different that helps us understand why some progress, why some don't, why some are symptomatic, why some are asymptomatic, looking at the same kind of a behavior. And so this is sort of a beginning of this work that we have spent many, many years to sort of now take it to the next level and see if there is a way that we can use this in a clinical setting. So I wanted to thank the 2 students that I've had that have done significant work as part of their PhD projects with us, Dr. Ramapa and Dr. DeAngelis, who are our clinical collaborators that I have worked with them for over 20 years, and everybody else has been a key part of this work. And all of the students over the years, including Gabe and Noemi from Dartmouth, who have been a part of our team and have helped us with our projects. So thank you very much, and I'm happy to answer any questions you may have.